We know that each of you have great ideas, ideas for new technologies, ideas to harness your volunteers. You've got skills, you've got support. But guess what, folks? Along the way, there are going to be roadblocks. It's not going to go the way you think it's going to go. You're going to hit problems. You might even fail, and fail miserably. But that is okay, because in failure, it means you took a risk, and that you can learn and pick yourself up and try something new. What you may find is that for many of you, that last mile, getting your technology, getting your services, getting your program to the people who need it most is the hardest. Now, we're going to have a great panel with 3 people who, not so long ago, were sitting in your seat. They've done some tremendous things, but more than that, they're going to share with you today some of the tactics that they used to get their services that last mile. I think some of the lessons that they learned are going to surprise you. So it is my pleasure to introduce to you first Molly Christensen of the organization Living Goods. Molly, come on up. Now, at Living Goods, Molly and her organization asked herself, how do we create a new model, a sustainable model for healthcare for Ugandans? And this was their answer. What if you had a whole army, 700 women, who were like Avon ladies, Amway salespeople, but who were trained in healthcare? But they would go door to door selling things like bed nets and sanitary products and cook stoves and pharmaceuticals. They would be selling them for below market rate and bringing home $2 to $4 a day. Does that sound like a sustainable model? Indeed. It definitely is. But 11 years ago, Molly was sitting in a chair unlike yours and thinking that what she really wanted to do was be a doctor. Are there any doctors, would-be doctors in the house? Well, I think you can learn from her example that there are many, many roads. And we'll hear what took her along her path. Next, I want to introduce you to Ben Liu. Ben, come on up. Ben literally was, a year ago, sitting in your chair. He was an undergraduate at Rice University, a biomedical engineer. Give it up for Rice, yes. And he and his biomedical engineering team had developed 6 different devices, including a kind of cool salad spinner that they were going to use as a centrifuge, and cell phone technology that could be used for hemoglobin testing. Great inventions, right? Then Ben won a fellowship to go and bring these 6 devices to Swaziland to see if he could get them in use in that country. Well, needless to say, it did not go exactly as Ben thought it would go. And he learned an awful lot along the way, but was successful in getting something called the dose right invention into the hands of folks in Swaziland. So Ben is here to share what he learned along the road. Finally, I want to introduce you to Sonia Sarkar with Health Leads. Sonia, come on up. In 6 years, Sonia went from being a student volunteer in the suburbs and in the city of Baltimore to being the chief of staff of Health Leads. Now she leads an organization that deploys 840 student volunteers, college students like you, in 6 cities, serving 9,000 clients with holistic support. I think what Health Leads recognized is that you can't just treat the disease. You have to look at the whole environment. You have to look at the fact that these are families that need childcare and employment and better food and housing and address all of their needs. And the good news is that there are services like that in our country, but there was a gap. How do you get the clients the services they need? And that's where undergraduates and graduate students step in. That's what Health Leads does. So thank you for joining us. I'm going to pick up this mic, and let's launch in. So, you know, I imagine along the path to success that you've enjoyed, there was a point when you had to change course, when it didn't go exactly as you expected and you had to pivot. Can you tell us about a moment like that that happened for you? Molly, let's start with you.
Sure. So when I was an undergrad, I was pre-med, and figuring out what I wanted to do with my life, and decided to take some time off from school and to go live in southern Mexico, working with a doctor down there. And now what I was tasked to do was to work on a cervical cancer project. Actually, while it's not technically difficult, I was tasked with doing pap smears for low-income women in several villages. I quickly realized it was a fairly inappropriate role for me to be playing because folks thought that I was much more experienced than I was and started asking me about all kinds of health issues that they had. So I had to kind of take a step back and think about how I was going to use the rest of the 6 months that I was supposed to be down there to do something meaningful and to contribute. So I spent the following couple of months talking to lots of folks and doing a lot of listening. I talked to the community health workers that I was working with. I talked to a lot of community members, to nonprofit leaders, to community leaders, to some government officials. And where I ended up was in sanitation. So I recognized and I heard over and over again some of the challenges that these several communities faced with sanitation. And so I ended up spending the final several months and then returned several more times over the following several years to help facilitate the building of several hundred composting toilets. And that's really what propelled me on my path in public health and in global development.
Well, thank goodness Molly took the time in her junior year at Brown to go into the developing world and see what were her best skills. What do you think emerged for you as the core competencies that led you away from medicine and into the role you play now in a nonprofit?
I think that there were probably several things. I think, I think it was my ability to really be able to build relationships with folks in all kinds of roles and to build trust among both the community members and the community health workers who I was working with, as well as kind of garnering the support of some NGO leaders, and then coming back to the U.S. and talking with a bunch of different Rotary clubs and other folks in this country who had resources that they were interested to contribute to really convince them that this was a good use of their dollars. So it was about relationships and I think really, thinking about, for myself, I think it was really thinking about looking upstream. So, while I had kind of a passion for wanting to do something good in the world, and medicine was an obvious choice, but really starting to look upstream, what are some of the other issues that communities are challenged with that can really help us to avoid some of the problems that you get when someone actually comes into the doctor?
Right. Right. I'm sure that Molly would have made a fantastic doctor, but those same skills of listening, of being in relationship with people, of building trust, she's used in a completely novel way. Ben, how about you? You were a hotshot engineering student who wanted to make great technology to change healthcare in Africa. What did you learn once you hit Swaziland?
Well, so it was quite interesting because a couple of weeks into Swaziland, we actually realized that a lot of the technologies that we thought would be successful in Swaziland weren't as big of a need as we needed. And for example, the main project that we thought would be successful was a national transport system that we could help provide them with. But in actuality, the government and the Clinton Health Access Initiative had already been working on that without our realization. Also, we thought that blood diagnostics, as you had mentioned earlier, would have been very useful for them. But again, the government had been able to invest in 1,400 of the gold standard devices. And so a couple weeks in, we kind of had to go back to the drawing board and realize that what we thought was a big need in Swaziland, in actuality was not. And so we kind of got lucky in the fact that from our discussions with some of these healthcare providers, they actually found need for some of our other technologies, and we kind of built our relationship from there. And I guess what I really learned was that you can't really assume that you have a good understanding of what their needs are unless you actually go there and take a look for yourself.
So let's paint the picture. You and your team from Rice get to Swaziland. You have an 8-week internship. Around week 2, you realize, wow, they don't even need these devices because they've already solved these problems on some level. But I've got 6 devices. Maybe there's something I can pull out of this. By around week 4, you're talking to lots of people, including high officials, and they recognize that, wow, maybe there's something in this dose right.
Right.
Tell us about dose right. Did you bring dose right?
I did.
It's hard to show.
Don't want to turn this into an advertising campaign, but basically dose right ensures the accurate dosing of liquid medications. So what it is, it's a syringe clip. It's kind of like a little Lego piece. It's only one of these. This is a whole series. But you clip it into a syringe, and it basically ensures that you can only drop a specific amount of medication. And it seems like a very simple technology, elegant technology, but in actuality, the accurate dosing of liquid medications is a big problem in the developing countries or in resource-poor countries, because a lot of the syringes that they have are defective, either because they're reusing it so often that the markings come off, or because the markings are not right to begin with because they were cheap, and that's why they ended up in these resource-poor settings. Additionally, some of the healthcare providers, they actually have like poor eyesight, or their health literacy is low just because they haven't had access to these technologies before, and so they don't have a solid understanding of how to use this technology.
So Ben, how many times did you have to go back to the head of public health and pitch your ideas before they said, oh, well, maybe that'll work?
Yeah, it's funny because we had actually met with the head pharmacist, I think, 2 times before, and it was similar presentations. I mean, we had discussed similar technologies that we had. 2 times before there was that aha moment for the pharmacist, because it was all about framing how your technology can be used and what specific use, what specific plan you have for that technology. So when the pharmacist first saw our technology, she didn't think to incorporate it into the National Prevention of Mother-to-Child Transmission of HIV/AIDS program that they had just started launching. It wasn't until I had met with the Clinton Health Access Initiative, and they were working with the ministry to try and start up this PMTCT initiative before they encouraged us to go back, reframe how we're pitching this technology, reframe how we can use this technology before the pharmacists agreed to, or really got excited about what we had to offer.
So now you're in my territory, which is communications, and it's really about figuring out the right angle, right? The right framing. Same device, it's this dose right, but once you made her realize that it could be used for this maternal HIV prevention campaign that she was already involved in anyway, then the light bulb went on for her. And you had to frame it in that exact way before you got buy-in from a major constituent. Well, Sonia, I'm wondering if there was an aha moment for you. You know, you were Johns Hopkins undergrad. Sonia, by the way, has attended every single one of these CGIUs. This is her 5th CGIU. She came up through this program. Was there a moment when you knew, wow, this is really what I want to do with my life?
Yes, absolutely. So we have an almost physician on the panel and an engineer. So I'm pleased to report that when I showed up for my freshman year at Hopkins, I wanted to be both an engineer and a doctor. Very, I know, underachiever, yes. And actually fell in love with a number of public health courses that I took early in my time at Hopkins. And I remember sitting in class and hearing professor after professor tell these great stories and rattle off these statistics about Baltimore City and the health disparities that we were facing in the communities that were directly outside the doors of Johns Hopkins. And I remember thinking, you know, as I was sitting there in class, that if I was sitting next to one of the greatest healthcare institutions in the world where patients have access to high quality care and the care is readily available, there had to be something missing if the health outcomes still looked the way that they did in Baltimore City. And in my sophomore year, had the good fortune to join an organization called Health Leads and co-found our Baltimore site. And I remember that the aha moment for me with Health Leads was, it was a cold winter day in November, a typical Baltimore winter. And I had just begun volunteering at what we called a family help desk inside of the Harriet Lane Clinic, which was the Johns Hopkins Pediatrics Clinic. And what we were doing is we were working with families to connect them to the resources that they needed to be healthy. So job training, childcare, health insurance, food assistance. And as I was sitting at the desk, this young mom came over to me. She had just been in the emergency room for the 3rd time that month because her youngest child, who was 3 years old, had been suffering from lead poisoning. And the reason that he was suffering from lead poisoning was because there was paint, lead paint, peeling off the walls of their old Baltimore row home. These are row homes that were built decades ago when lead paint was still available or was still allowed. And she must have been at the time maybe 20 or 21. I was 18, so she was just a little bit older than I was. But what really stood out for me was just how tired she looked. I was tired because I had been studying for midterms, but this was an entirely different level of just weariness. And she came over to me and we began talking, and she told me the story of how she and her 3 children lived in this Baltimore row home with 11 other people. And she looked at me and she said, I just want a house that's actually a home, and we'll stop killing my kids. And for me, that was an entirely different outlook on healthcare and on life. It completely in that moment obliterated the way that I thought about the healthcare system as a place where people go to get medication prescribed or a place where they go to get a test done, and made me really think about this sort of 360 view of how patients can get access to everything else that impacts their health, as Molly was saying, from an upstream perspective.
So within the next 6 months, you're a freshman or a sophomore. You're a sophomore, 18-year-old sophomore. You worked with her to secure better housing, food stamps. What were the outcomes as an undergraduate of your working one-on-one with her?
Absolutely. So the first thing that we did was we talked through all of the challenges that she was facing. The most immediate one was that because she had been to the emergency room so many times in the past month, the ER bills, the emergency room bills that she was getting were extraordinary. Neither she nor her children were enrolled in health insurance, so we were able to find a program that they were eligible for, get them enrolled. But then the bigger question was, how could we get them out of that house, since that was really at the root of a lot of their problems? And so we talked about enrolling her in a job training program. It was a 6-month program, and at the end of it, she would be eligible to become a nurse's assistant. We also enrolled the family in food stamps so that they had a little bit more healthy food, but also more dispensable income to put towards something like a rent. And 6 months after I began working with her, she had actually come back to the clinic for her son's well-child visit. And she came over to me, she was waving and gesturing. She said, I finally saved up enough money, just a little bit, to move to a neighborhood with a slightly higher rent. And she and I were talking about how it was just that very small, tangible change that was going to put this family on a pathway to not only better health, but better well-being as well.
So Sonia didn't have to go to Africa or India to do good work. She went probably a few blocks from Johns Hopkins and had a tremendous impact on the life of a family as an undergrad, as a sophomore, and went in 6 years from being that student volunteer to being the chief of staff, leading hundreds of volunteers. Molly, for you, did you have an aha moment when you thought, gosh, it's not being a doctor, it's being in this nonprofit world that I can make a difference?
I've had several aha moments, and I'll speak to one of them, which is so after undergrad, I was working in public health, both in the U.S. and in the developing world. And when I went back to graduate school, I was in one of the classes I took my first semester. There was a speaker that came in who really inspired me, and this was an aha moment for me, which has propelled me to do the kind of work that I'm doing right now. And this was a leader of a social enterprise called Vision Spring, and they are improving access to reading glasses in the developing world by using a sustainable business model for distribution. And so at the time, I was in an MBA program and in a Master's in Public Health program. But it was really one of the first times that I so clearly saw this intersection, you know, recognizing my own passion in public health and in global health, and really seeing this very tangible example for how you could use business and you could think about sustainable models for addressing these large problems. And it occurred to me really that, you know, in order to really take something to scale, if we really think about how massive these problems are that in around the globe that we want to try and solve, if we really are going to think about taking some of these solutions that we have, which are terrific, inspiring, exciting solutions, there are not enough philanthropic or public dollars to make that happen. So we've got to think about how can you use the private sector, how can you use commercial capital, and how can you use sustainable business models to really address some of these problems. And so that was really an aha moment for me, which then propelled me to spend my first summer in graduate school in India, working with this organization, Vision Spring, as well as with a large corporation, Unilever, really understanding some of their rural sales distribution models, spending the next summer with Acumen Fund, that is one of the funders of some of these social enterprises that are looking to grow, and then which ultimately led me to, after graduate school, to Living Goods, where I am right now, and where we are really thinking about sustainable models for increasing access to primary health care.
I had the privilege of working with Katie Chatou, who's in the audience, on a show about social innovation, and she interviewed a man named Tom Freston, who's the chairman of the One Campaign, and he said to her, you know, Katie, 10 years ago, if you came out of business school or college, you'd probably go to Wall Street. But the bloom is off that rose, that Wall Street rose, and now those same people with the same kind of acumen are going into social innovation. They're using their business knowledge, they're using their understanding of how markets work and capital works to solve some of our biggest problems. And I think that's where so many of you are, at that intersection of knowledge and vision. Along the way, you're going to hit a few roadblocks, as these folks did. Talk about that last mile, the hardest mile in many ways, getting your product, your services into the hands of those who need it most. Ben, can you share some of your last mile stories?
Sure. So when I was in Swaziland, we had some downtime, as you had mentioned. There were a couple of weeks when we weren't exactly sure what we wanted to do. But what we did is we worked with the clinics to try and anticipate problems that we would have if we did have the opportunity to implement technology. And a lot of the problems weren't what we would have thought. For example, a lot of these, labeling some of the clips, right? So the easiest way to label a clip, you would think, is to just write down what specific dose is on there. But you know, we didn't anticipate that so many people would have vision problems, that the easiest way would just be to color code them. Another one was kind of an engineering logistics problem, is what type of plastic you want to use for your clip in order so that it can be used for thousands of times, not just so that it can be used once and then disposed away. As we progress further, there are a lot more logistical problems, such as transportation. When you think about it, once we knew that this technology, there was interest in this technology, and there's an opportunity to implement this technology, when you think about transporting 200,000 clips from Texas or from California, somewhere in the United States, all the way to little Swaziland in southern Africa, it's really difficult. It's hard enough to get yourself to Swaziland. You have to fly, all over the place, have 2-3 layovers. But you can't just FedEx these clips over there. There isn't quite the same transportation infrastructure in place. And so that was actually one of our biggest hurdles that we needed to clear, how to transport our clips over there and how to cover that cost.
How did you transport? What was your workaround for having no FedEx?
So initially our thought was, we could just have some of our interns bring the clips over there, and that would work well for smaller batches of the clips. But it wouldn't work for, transporting 200,000 clips. So we ended up having to go through established transportation infrastructures and having physicians or people from the ministry come pick up some of the clips, even if it wasn't being directly shipped to the clinics. And that's actually something that the Clinton Health Access Initiative helped us out a lot in that area.
So you didn't try and do it by yourself. You brought in other groups like Clinton Health Access to work with you.
Right.
How about you, Sonia, at Health Leads? What are some of the challenges you face in that last mile?
One of the last mile challenges that we faced was, it's one thing to have a model or a program that you think works or that you're testing to work. It's another thing to have it be fully integrated into the system that you're trying to tackle, which in our case was the healthcare system, and on an even more granular basis was the individual clinics that we were working with. And so one of the challenges that we really tried to tackle is, how do we ensure that the physicians in the clinics where we operate are using Health Leads as a service that's available to them on a regular basis? Just as they would write a prescription for medication, how do we ensure that they're also writing the prescriptions for food, for employment, and for housing? And as you can imagine, asking about these types of issues aren't that easy. It's awkward. If you don't know exactly how to address the problem or bring it up in conversation, you can get into sort of dance with your patient. And so one of the tools that we implemented was a very basic 5-question screening tool that asks certain questions, such as, do you have enough food at the end of the month at home? Do you need assistance with job training? And these resource screens are actually administered as part of the basic paperwork that every patient gets when they walk into the clinic. So if you think about when you have to fill out your name and your health insurance card number and all of that, this screen is administered then as well. The doctor can then refer to that paper as they're in conversation with their patient in the room. And we found that just by implementing a very basic tool, it's just a piece of paper, we were able to significantly increase the amount by which physicians were referring patients to us, and then the amount of back and forth that our volunteers and physicians were able to get into about the actual case and the outcomes.
So a low-tech solution.
Exactly.
Molly, how about you and Living Goods? You have 700 women out there selling everything from cook stoves to bed nets.
Yeah, so I mean, the challenges that we really were seeking to address as we designed Living Goods really come down to that last mile. So as you look at the health workers in the developing countries, there are not enough nurses and doctors, and so you're increasingly needing to shift tasks, called task shifting, down to lower skilled workers. So there are all kinds of cadres of community health workers. The challenge with community health workers is that generally they're volunteers, and in some cases they may be paid, but there's only limited amounts of time when there is funding available. And so you get really high rates of attrition, and it's really hard to ask folks who have large families, have other, need to be earning money for their families to be doing this really important work on a volunteer basis. At the same time, you have supply chains in the public sector that are really broken. So if you get sick in the middle of the month and you go to the clinic for malaria, they may be completely out of stock with the medicines you need. Plus, you have folks living long distances from those from the health centers. And finally, while there does exist some private sector, drug shops and stuff, they're largely unregulated. So you're really not guaranteed a quality drug. Their counterfeits abound, and so you're kind of risking your life or your child's life with the possibility of buying a counterfeit drug that's really not going to actually lead to the health outcomes that you're looking for. And so what Living Goods is doing is we're trying to bring those products and services to folks' doorsteps. So we really combine what would, kind of a traditional community health worker model with this direct selling model, the Avons, the Amways, Shakleys, Herbalifes, these women entrepreneurs. They can earn an income, make money selling products that people need every day: soap, sanitary pads, diapers. But they also carry those essential health products: the malaria treatment, the diarrhea treatment, the bed nets, fortified foods to improve folks' nutrition. And they're working in the same communities where they live, and they're going door to door, talking to their community members, selling them the products they need, and therefore being able to really affect change by identifying sick children, by being able to refer children who are sick to further treatment if that's needed. And I can give just a quick example of one of our community health promoters, Pauline, who earned income before joining Living Goods. She was a tailor, and she'd always wanted to work as a nurse, but never had the money for school fees. She has 2 young children, 2 twins, and she now works a couple hours every day, going door to door in her community. And she's able to earn enough money to pay the school fees for her own children. So she earns an income. She's earning the respect of her community members. She's now the trusted advisor to a number of folks in her community. And when a child is sick in the community where she lives, they can call her to come to the house to treat the child. And so she is really able to not only have an impact on her own family by earning an income, but she's able to really have an impact on the community where she lives.
We only have about 3 minutes left before we open it up to your questions. So I want to go to some very tactical advice. If you had to offer everyone in this room a piece of advice as they head out to do their own commitments, what would it be? Sonia, let's start with you.
I would say know your audience. One of the best things that you can do and that I really learned through Health Leads is how do you talk about very specifically what you're doing in a different way depending on what the audience is while still retaining the core message. And if you can do that well, it will take you and your commitments to extraordinary levels.
Thank you. Ben?
I think that I'd really have to recommend, especially when you're marketing a product, really be professional, but also understand that when you're marketing a product, you should also listen to your audience as well, and really try and incorporate their ideas into what you're doing.
Molly?
My advice, particularly for folks who have commitments in other countries other than our own, and if you have kind of ambitions to be working in development, is spend time living abroad. And I guess this would relate also to commitments here in the U.S. So spend time in the communities where you want to affect change. There is no greater experience that you can gain and draw from as you continue to learn in the future. I mean, the learnings that I have today that I apply every day in my work at Living Goods, the majority come from my experiences in Mexico, Peru, Ecuador, India, South Africa, Uganda. I only wish I could spend more time than I currently do in Uganda. Especially when you're young and you aren't committed to families and to other things, I mean, just get as much experience as you can in the communities where you want to work.
What's the most satisfying thing for you in the work that you do now? Sonia?
The most satisfying thing for me is the ability to wake up every day and actually go to a job that I love. I graduated in 2008, which was right around when the stock market crashed, and have a lot of friends who are not only in jobs that they don't love, but I have other friends who can't even find a job. So I feel incredibly fortunate to be able to actually do the work that I started as a college student and still continue it now.
And you get to see the benefits. I mean, you see families who have better food and better housing because of what you do. There's kind of tangible feedback for you.
Exactly, for both the families and the volunteers, just to be able to see that really get borne out in real time.
Ben?
When I was a student in Swaziland, I think one of the most satisfying things for me was knowing that, it wasn't realistic that you'll be able to solve all of these people's problems, but knowing that we can check off even one complication that they face every single day, that's it kind of makes their life a lot easier.
I am incredibly inspired by the women that we work with every day, and so I wake up every morning thinking about, how can I support them to do their work more effectively, and as a mother myself, I think, how can I make it so that as many mothers as possible have the same sense of security for their children that I have here.
Well, here are 3 stories of success, of detours, of roads not taken. What are your questions for these folks? I think there are people walking around with microphones.
Hi, so this one's for Ben. My name's Divyada. I'm a doctor, and I'm currently at the Kennedy School. And my commitment is to bring medical technologies to emerging markets, so something that you're doing. But what we're planning to do is bring a multidisciplinary team starting in the summer this year, going to India and planting ourselves in the hospitals there to look at healthcare needs, and then bringing them back to our lab so that we can work on technologies. The question that I have is, I've seen these kind of programs like Stanford Biodesign program that you might be aware of. I'm not too sure about the RICE program, but these kind of programs that have existed, they've created these technologies, but it's really hard to actually get them to market and actually get people using them so the impact is actually created. So my question is, how do we ensure that these products get to market and hence they have the ability to create the impact? One idea was to get a co-creation model where engineers in India are working with us in creating these, but I'd love to hear your feedback on how we could do that.
So with the dose-right syringe clips, we actually contracted out the production of our clips to Third Stone Design, and they've been gracious enough to agree to upscale our project and help us work with Clinton Health Access Initiative to go out there. I guess my advice to you would be to really find a niche, find other people who are working towards that same goal, and really collaborate, because there are a lot of people who are out there trying to accomplish the same goals. And if maybe your organization by itself cannot achieve that goal, working together with other organizations, I think the production will be a lot better.
Other questions?
This is specifically for Molly. It might be a little specific, but I'm sure everyone could kind of get something out of your answer. You said you worked with composting toilets before. What were your experiences with the community adopting them? Were they readily adopted by the community, or did you kind of have to sort of prod? And after you sort of phased out, how was the community able to maintain them themselves?
Yeah, those are great questions. So part of why we chose composting toilets, because it was actually a design which had been used in a number of other communities, kind of surrounding communities there. So there was already some kind of embedded knowledge about the technology and some support systems to kind of support the building of that technology. And part of what we did, I mean, they formed in the community where we worked. They formed a local committee that was in charge of the project, and that was really important in terms of just getting kind of the buy-in of the local leaders. And we also used local materials as much as possible, so that there was, particularly for the materials that were building kind of the housing part of the toilet. So, as much as possible, we were kind of trying to think about, how can we, reduce costs? How can folks also aesthetically create it how they like? So some folks use corrugated metal, other folks used like straw, other folks built it out of Adobe. So really they could kind of design it, families could design it how they wanted to. And then finally, to your question about making sure that folks continue to use it, I was working really closely from the time that I was down there with the community health workers that were working in the community, and similarly with local leaders. And it was really about kind of making sure that there was local ownership over this. This was not my project. This was their project. This was their their initiative. I was helping to fundraise and to facilitate kind of bringing in the right resources to make it happen.
I think we have a question right here.
Hi, Ben. This question's for you. My name's Jenny. I'm also from Rice University. Yay, owls. Okay. So I have a question. In your introduction, it said that you're currently a medical student. Is that right? And also, so my question is, how have you been able to bring your passion for public health and your work and experience into medical school? And kind of how do you see yourself being involved in both medicine, public health in the future? Because I think I am personally pre-med, and I know a lot of people who feel kind of they're at that crossroads and they don't know which way to go, public health or medicine. So I want to know how you've been able to negotiate that.
That's something I'm still grappling with, actually. So it's a good question. In medical school, you're going to be very busy, but there are lots of organizations, lots of events on campus that I try to go to, especially for global health, because that's an area that I hope to eventually work in again. I think it's a little bit easier to shift your focus to domestic public health as well. As a medical student, you'll have lots of opportunities to go out into the community for service projects, running a free clinic, and that way you can both advance your clinical skills to help you become the best physician you can be, in addition to giving back to the community and reaching out to those people who are underserved. Did I answer all of your questions? Sorry. Okay.
Right here in the front.
This is for Molly. I thought it was interesting when you described your experience in Mexico, sort of as a community health worker yourself, and the responsibility when you're doing these pap smears you felt to address all of these other medical concerns that would come up when you were playing that role. And then now, interestingly enough, having your employees with Living Social and this task shifting that is very much a trend and a very interesting idea that is being implemented. What are your strategies for managing those responsibilities for your employees?
Yeah, it's a great question. So, we have a very kind of rigorous and extensive training program that we put our community health promoters through, and they have to pass certain tests to be able to be allowed to, to diagnose and treat malaria, for example, or to diagnose and treat respiratory infections with antibiotic. And so that's something that kind of the quality control and monitoring is something we think about a lot. We're increasingly going to be employing mobile technologies to do more quality control and monitoring. Right now we have our field staff doing a lot of that, so they follow up on a sample of customers to ensure that folks are treated correctly. And we'll increasingly be using mobile technology and to do some of that. But I mean, it's a critically important question, and that's a big part of what I think about every day in ensuring that we're providing really quality service and products to folks.
And just to jump in on that question real quick, I think there's this interesting trend going on in healthcare around how do you leverage alternative workforces to enable all of the different people who are in healthcare to operate at the top of their license. And I think, to your question around how do you essentially divide responsibilities and then ensure quality, one of the things that health leads volunteers do in the clinics that they're in is establish a very clear division of responsibility between the social workers, the legal team in the clinic, the physicians, the nurses. And I think there is this sense that you can actually enable all of the different professions within healthcare to really achieve maximum efficiency and be able to spend time on the things that their specific skills and competencies and experiences enable them to do. And so I think increasingly we'll see that take place not just in global health, where it is almost a necessity, but in domestic health as well.
So there were many, many rich lessons, I think, in the stories of our three panelists, but some of the lessons that I heard were that don't reinvent the wheel. Collaborate with other groups. Listen carefully to your stakeholders. Go into the communities that you hope to serve and learn about them and live with them and understand them. Think about what are the sustainable models that I can create for my organization or my project so it can live beyond me. Pivot. You might be on this path and you're going to have to take a side road along the way. Be patient. Sometimes you have to go back time and time again before you can frame it just right so that someone can hear your message. And be resourceful. You're smart, resourceful people. If you are, you're going to find a way to make it down that last mile. So we are going to pivot at this point and have you engage in your own conversations. All of us will be mingling through the crowd, but here's your assignment. I want you to introduce yourself to each other in 6 words, the 6-word bio. Okay, here's mine. Hi, my name's Wendy, and I tell visual stories for social change.
Hi, my name is Sonia, and I enable physicians to write prescriptions for patients' true health needs.
Hi, my name is Ben. I look to improve healthcare access and quality through biomedical technologies.
Hi, my name is Molly, and I build sustainable solutions for global health.
So if you can do that, introduce yourself in the 6-word bio, and then that'll leave most of your 10 minutes to talk about the question on the table, which is, what is the biggest last mile challenge that you think you're going to face in your commitment, and how can the collective wisdom of your table help you to address that? We're going to ask a few of you your tables to report back your greatest findings, what got most traction. So maybe you want to assign somebody to do that as well. So you have 10 minutes to do that, and then we're going to go see Jon Stewart. Wow, that was a quick discussion period. But we want to hear from some of you, and I think there are people with microphones. So can we hear what the last mile challenge is and what some of the solutions your table came up with? Here's someone from this table.
Well, our group was discussing the issue of sustainability once these projects have been implemented, once they pull out. I mean, what is there really left? So that was something that we feel is definitely a challenge within like the last mile of being able to reach your goal.
And did your table have any suggestions for how to make your commitment sustainable?
Yeah, definitely laying the foundation, so teaching the people within the community how to carry out your project. So once you withdraw from it, I mean, you can really only be there for so long at times, and you know, how they can carry on and improve their own communities.
And did you have any ideas about resources, you know, how to get money and funding continuously?
Yeah, well, I mean, it was a pretty brief discussion period, so we couldn't really touch on that fully, but definitely looking to organizations such as like Doctors Without Borders. Raul's a member of Engineers Without Borders. There's definitely sources with like seed money that can, I mean, give you funding to lay the foundations within these communities.
Great, thank you.
Thank you.
How about another table?
Hello, I'm trying to promote awareness in universities, especially when universities are creating dining plans to cater to people with celiac disease and gluten intolerance. And for those of you who don't know what that is, some people are intolerant to gluten, which you find in like wheat and bread products and things like that. And it's an extremely serious issue, but not a lot of people know about it because it's a pretty recent phenomenon as opposed to things being diagnosed. And so I was asking my awesome table about how I should go about promoting my plan, because I want to create a comprehensive dining plan that can be easily distributed. And they recommend that I should start talking to, there's a doctor at UVA who's an expert on celiacs, and I told, kind of nervous to email her, but they're like, you should do it anyway, because the goal is to get it out there as soon as possible, and getting the support of doctors and nutritionists who are experts in this field is really like a crucial first step to getting out the word to these universities so that students can have safe, stress-free dining experiences during their first couple years at their undergrad school.
Thank you.
So, yeah, thanks.
And to broaden that question even further, it seems to me it's a question for many of you. You're trying to create awareness of an issue, whether it's sex trafficking or alcoholism or celiac disease, and it's a hard topic to get people to really tune into. This table had some interesting ideas on how to best deliver those awareness messages. Does someone want to talk about that?
Hi, my name is Natasha Forsina, and I work with Spark Microgrants in Uganda and Rwanda, and what we've kind of adapted a model of is called a facilitator corps. We work with university students from the National University of Rwanda and several other universities, and really look to our facilitators, who are student interns, to kind of give us an into communities. We go back to their home communities where we already kind of have a knowledge base where we can be welcomed in versus showing up in a new place and not really having connections. And for us, that's allowed us to get to work a lot faster in the communities that we work in.
So understand who your audience is and find messengers who are relatable to that audience. That's what I heard when I sat on that. This gentleman in the front.
I work with Advocates for World Health, which is a distributor of medical supplies and equipment to hospitals in developing countries. And part of our limitation is finding a home for a lot of these supplies. There's a great need. And we work with large international relief agencies to help us place these supplies. But while sitting around with our table, I realized that I can work with students and small agencies as well to help identify the needs, and a lot of these initiatives are more grassroots to help me identify where to place these supplies.
Great, great. Other tables ready to report back? No? Well, I think everyone is wanting to go see Jon Stewart and Bill Clinton. And just on behalf of the Clinton Global Initiative University, I want to thank Sonia and Molly and Ben for being awesome panelists. And we will all be here for the rest of the evening, so come on up and talk to us individually. We look forward to meeting you. Thank you. Ladies